Hello to all of you. I am Dr. Shilpi Agarwal. Today we will be discussing anatomy questions for Grand Test 182, and the questions they are from question 209 to question 222. So first of all we will come to the question 209. If we see this question 209, this question is on the nerve of Risberg. When we talk about the nerve of Risberg, this is actually the sensory root of facial nerve. This is the sensory root of facial nerve, and it is also known as nervus intermedius, also known as the nervus intermedius. Now this sensory root of facial nerve, it is carrying the sensory fibers as well as it is carrying the parasympathetic fibers. So the answer for this question will be, it is carrying sensory as well as parasympathetic. Answer is B and D. Now let's discuss how it regarding this nerve. Now this picture is showing us the origin of the facial nerve, the motor root and the sensory root. This over here is the motor nucleus of the facial nerve, and it winds around the abducent nucleus and then it comes out and it is traveling in the facial nerve. Another root, that is the sensory root. The sensory root, it is coming from the superior salivatory nucleus as well as from the nucleus tractus solitarius, and the parasympathetic fibers, they are arising from the superior salivatory nucleus, and the sensory fibers, they are coming from nucleus tractus solitarius. The fibers, they come over here and they form the sensory root, and this sensory root is known as nerve of Risberg or the nervus intermedius nerve. Then they both connect to form the facial nerve. Now initially this root is different, sensory root and motor root, and this sensory root is lying between the motor root of facial nerve and the vestibulocochlear nerve. Just before the presence of the geniculate ganglion, this sensory root, it joins with the motor root to unite with that. So this point, at this point, this is the point where the geniculate ganglion is present, and just before the geniculate ganglion, this motor root and sensory root, it will combine each other, and then further the branches are given. So the sensory root and the motor root, they combine to form the facial nerve, and this facial nerve, it is passing through the internal aqueous meatus and it is related with the middle ear, and then it comes out through the stylomastoid foramen, traverses through the parotid gland, and the terminal branches are given within the face. The motor root, the root, it is going and it gives branches to the muscles of the face, the facial muscles. Apart from that, it is also giving muscle to the styloid muscle, the posterior auricular muscles, and the posterior belly of digastric. When we talk about the sensory root, as we have just said that the sensory root or the nervus intermedius, the sensory root or nerve of Risberg, this is carrying the sensory fibers as well as the parasympathetic fibers. So it is carrying these two fibers. Now the sensory fibers, they are carrying taste fibers from the anterior 2/3 of the tongue through the chorda tympani branch, as well as the sensory fibers are distributed, or they are carrying the sensation from the skin of external aqueous meatus and the canal, as well as the mucosa of the nasopharynx and the nasal cavity, and towards the palate region also. Towards the palate region as well as towards the floor of the oral cavity. So the sensory fibers are responsible for that. Then when we talk about the parasympathetic fibers, these fibers, they are originating from the superior salivatory nucleus, and as we can see in this picture, after arising from this superior salivatory nucleus, it is following a course and it will be traversing through the ganglion. Over here we can see this is the pterygopalatine ganglion, and this is the submandibular ganglion, and it will be finally supplying the lacrimal gland, the nasal and the palatine glands, as well as the submandibular gland and the sublingual gland. The parasympathetic fibers, they are going to these glands through different branches of this facial nerve. For the sublingual and the submandibular gland, the parasympathetic fibers, They are running through the chorda tympani nerve and then they relay in the submandibular ganglion and then it is distributed into these glands. When we talk about the lacrimal gland and the nasal and the palatine glands, then the parasympathetic fibers, they are running through the greater petrosal nerve, which is the first branch of this facial nerve, and then it is distributed or it relays, this nerve it relays, it follows a pathway and finally it is relayed into the pterygopalatine ganglion, and then further the postganglionic fibers are distributed to these glands. If you just see the pathway, the parasympathetic pathway, the superior salivatory nucleus, from the superior salivatory nucleus, this sensory root it arises, also known as nervus intermedius. Then it joins with the facial nerve, and after joining the facial nerve, the fibers they reach towards the chorda tympani, which is one of its branch, and this chorda tympani it joins the lingual nerve, and this lingual nerve it will go and relay into the submandibular ganglion. After relaying into the submandibular ganglion, the postganglionic branches they are distributed towards the submandibular gland. The direct branches are going over here, and few postganglionic branches they may pass through the lingual nerve and they are distributed to the sublingual gland. When we talk about the parasympathetic fiber, which will be passing through the great petrosal nerve, we have a portion of this nucleus termed as lachrymatory nucleus. From the lachrymatory nucleus, again this nervus intermedius it is arising, which joins the facial nerve, and the fibers are then passing through the greater petrosal nerve. The greater petrosal nerve, and this petrosal nerve it joins or it combines with the deep petrosal nerve, which is one of the sympathetic, which is a sympathetic branch arising from the sympathetic plexus, and this will form the nerve to pterygoid canal. This forms the nerve to pterygoid canal, which is also known as Vidian's nerve. Also known as Vidian's nerve. Now this nerve it goes towards the pterygopalatine ganglia, and then from here the further branches are given which will be supplying the nasal glands and the pharyngeal as well as palatine glands. Apart from that, a branch passes through the zygomatic branch of maxillary nerve, and from here it passes through the zygomaticotemporal, then finally to the lacrimal nerve, and this will be supplying the lacrimal gland. Now when we talk about the rest of the named nerves, one of the nerve is nerve to Risberg, which is the sensory root of the facial nerve. Another we have just described the Vidian nerve, which is nerve to pterygoid canal. Apart from this we have Arnold nerve or Elderman nerve. This nerve is the auricular branch of vagus nerve. Then one more named nerve is there, that is Jacobsen nerve. Jacobsen nerve is tympanic branch of the glossopharyngeal nerve. The tympanic branch of the glossopharyngeal nerve. So these are the named nerves. The tympanic branch of the glossopharyngeal nerve is also known as Jacobsen nerve. So now if we come back to the question, so the nerve of Risberg it contains the sensory fibers as well as the parasympathetic fibers. These are being carried by it. Now the next question is regarding the inguinal canal. It is regarding the inguinal canal and it is talking about the roof of the inguinal canal. So let us first discuss regarding the inguinal canal. Over here we can just view a schematic diagram which is showing the inguinal canal. The inguinal canal it is present just above the medial medial portion of the inguinal ligament, and it is having a deep inguinal ring and the superficial inguinal ring. The superficial inguinal ring is a gap which is present in external oblique aponeurosis, and the deep ring is towards the fascia transversalis, and a pathway is formed or a tunnel is formed between the deep ring and the superficial ring, which gives passage to the structures. And this inguinal canal, it is 4 centimeter long, and the direction of this inguinal canal, it is directed downwards. It is directed downwards and medially. So regarding the inguinal canal, it is 4 centimeter and it is having a superficial ring. This superficial ring, it is present in the external oblique aponeurosis, and it is just present above the pubic tubercle. Then we have deep ring. The deep ring, it is present as a gap in the fascia transversalis, and this is situated around 1.25 centimeter above the mid-inguinal point. Now the structures which are passing through the inguinal canal, it includes the spermatic cord in males and round ligament of uterus in females, which are passing through the whole extent of the inguinal canal. And apart from this, one nerve is passing, that is the ilioinguinal nerve. Now when we talk about the boundaries of this inguinal canal, they are structures which will be forming the anterior wall, posterior wall, roof and the floor. Now this picture, it is again showing this various muscles which are present over here. This is the superficial inguinal ring over here from, This is the superficial inguinal ring which is present over here, and the spermatic cord is coming out of this. The deep ring is situated over here at this point. So the spermatic cord, it traverses like this over here, and the various muscles of the abdomen, they are either contributing into the anterior wall, floor, to the anterior wall, roof or the posterior wall. Now the structures which will be forming the anterior wall. For the anterior wall, the structures contributing to the anterior wall includes skin, superficial fascia, then external oblique aponeurosis. These three structures, they contribute in whole extent to the anterior wall. And apart from this, towards the lateral 1/3, the contribution is also from the internal oblique muscle. The internal oblique is towards the lateral 1/3. So these are the structures contributing into the anterior wall. Then towards the posterior wall, in the whole extent, we have fascia transversalis. The fascia transversalis, it is contributing into the whole extent. Along with that, the extraperitoneal fatty tissue is there, and the parietal peritoneum. These structures, they contribute into the whole extent of the posterior wall. And apart from this, we have conjoint tendon. The conjoint tendon, which is formed by aponeurosis of internal oblique and the transversus abdominis. The conjoint tendon, it is formed towards the medial most aspect by the fusion of the aponeurosis of transversus abdominis and the internal oblique muscle, and this is contributing towards the medial 2/3, of the posterior wall. So these are the structures forming the posterior wall. Now when we come towards the roof is formed by arching fibers of the internal oblique and transversus abdominis. Towards the floor is formed by the inguinal ligament, and towards the inguinal ligament, it is forming the floor in the whole extent, and towards the medial side, the lacunar ligament is present, which is one of the extension of this inguinal ligament only. So these are the structures which are contributing to the boundaries of the inguinal canal, and if you see over here, the roof is formed by the arching fibers of internal oblique and transversus abdominis. So if you go back to the question says that the roof of inguinal canal is formed by, the roof of the inguinal canal will be formed by the internal oblique muscle and the transverse abdominis. So the answer for this question is A and C. Now the next question is, a person cannot adduct his thumb, and the nerve involved in this case will be. Now for the adduction of the thumb, we know that the muscle which will be responsible is adductor pollicis muscle, and this adductor pollicis muscle, it will be supplied by the ulnar nerve. So over here there is the lesion of the ulnar nerve. So first of all we will just discuss the ulnar nerve. Regarding the ulnar nerve, now this ulnar nerve, it is one of the branches of the medial cord of brachial plexus. From the medial cord of the brachial plexus, we are having the various branches, that is the medial cutaneous nerve of arm, medial cutaneous nerve of forearm, then we have medial pectoral nerve, the medial root of median nerve, and the ulnar nerve. If we talk about the rest of the cords, the lateral cord is giving the lateral pectoral nerve, musculocutaneous nerve, and the lateral root of median nerve. The posterior cord is giving upper and lower subscapular nerve, axillary nerve, radial nerve, and the thoracodorsal nerve. So the ulnar nerve, it is a branch of the medial cord of brachial plexus, and the root value of ulnar nerve is C7, C8, and T1. Now after origin of the ulnar nerve, it traverses, or it is related to the medial part of the third part of axillary artery, and then it runs down in the arm. In the arm it is not giving any branch, then just it is running just behind the medial epicondyle. So it is related to the medial epicondyle, it runs behind the medial epicondyle. Then as it comes in the arm, it gives the further branches, various branches are given. In the forearm, it is giving 2 branches. So if we talk about the branches in the forearm, it is giving supply to the flexor Now when we talk about the lesion of this ulnar nerve, regarding the lesion, If there is lesion of the ulnar nerve, then it leads to claw hand, and that is a partial claw hand. Now what happens in this situation, the partial claw hand, the hand is in such kind of situation. The fingers, the medial two fingers, they are flexed like this, and this happens because there is loss of or paralysis of the medial half, or we say the medial two tendons of the flexor digitorum profundus, and as well as there is loss of the lumbricals and interossei. So what happens in this, in the claw hand, there is flexion at the two interphalangeal joints, and then there is extension at metacarpophalangeal joint. Apart from this, apart from the claw hand, there will be weakness in the flexion at the level of the wrist. And as we know that the flexor carpi ulnaris, which is present over here, it will help in the medial deviation, or we say it helps in the adduction at the wrist joint. So this adduction at the wrist joint is also affected, and the wrist is slightly towards the lateral side. It is laterally flexed due to the unopposed action of the tendons which are present on the lateral aspect. Now if you go back to the question, now apart from this, one more thing is there, the various tests. The various tests which are used to check the intactness of this nerve. It includes the Book's-Froment test, then it includes the card test and the Igawa test. The Book-Froment test, this Book-Froment test, it is basically to test the adductor pollicis. So it is for adductor pollicis. In this we give a book and we put it in between the thumb and the index finger like this, and we try to pull the book. So what happens in this, because the adductor pollicis is paralyzed, so the person, he uses the flexor pollicis longus tendon, which is actually supplied by the median nerve, and when you try to pull the book, so there will be flexion at the interphalangeal joint, because the person is using the flexor pollicis tendon, the flexor pollicis longus tendon. So he uses that tendon, but the adductor tendon is not is paralyzed, or it is not supplied by over here due to the lesion. So there will be weakness present. So by this we can test the adductor pollicis. Next test is card test or the paper test. It is to check the, it is for the palmar interossei. The palmar interossei, they actually help in the adduction of the fingers. So we put the paper in between the fingers and we try to pull the paper like this. So what happens when you try to pull the paper and you ask the person to adduct the fingers, if the adduction is weak, you will be able to pull out the paper very easily. So we can check the palmar interossei by this, which are basically supplied by the ulnar nerve. And thirdly, we can also check the dorsal interossei, and that test is known as Igawa test. This is for the dorsal interossei. So now if we come back to the question. Now in this question, they have said that the nerve involved, that is the ulnar nerve, it is characterized by, so it is having a root value of C7, C8 and T1, and it arises from the medial cord of brachial plexus. The rest of the options, they are not correct. So the answer for this question is A and B. Now the next question is regarding the median nerve. We will just discuss the median nerve first of all. So regarding the median nerve, it is one of the branches, it is actually arising from the fusion of the medial root and the lateral root of median nerve. This medial root, it arises from the medial cord and the lateral root, it arises from the lateral cord. So the root value of the median nerve, it is from C5 to T1, and as it is coming down, it is actually giving no branch in the arm and it comes into the cubital fossa. it reaches the cubital fossa, and in the cubital fossa it is lying just deep to the bicipital epineuriosis, and when it reaches the arm it will be giving further branches when it reaches the forearm. So the branches which are given by this in the forearm, it is supplying all the muscles except the muscles which are being supplied by the ulnar nerve. So it supplies the pronator teres, the pronator quadratus, then apart from this it is supplying the palmaris longus, the flexor carpi radialis, flexor digitorum superficialis, and the lateral half of flexor digitorum profundus. So all these muscles are being supplied by the median nerve, and when we reach towards the hand, it is supplying the thenar, the three thenar muscles which are supplied by this. It includes the abductor pollicis brevis, then the flexor pollicis brevis, and the opponens pollicis. Apart from this, it is also supplying the first and second lumbrical. So these are the muscles which are being supplied by the median nerve in the hand. Now when we talk about the cutaneous supply for the median nerve in the palm, it is supplying the lateral 3.5 fingers. It is supplying the lateral 3.5 fingers, and the adjacent palm is being also supplied. And when we come towards the dorsum of the hand, it is supplying the lateral 3.5 nail beds of the fingers. So it is supplying these nail beds till the ring finger, half of the ring finger. So all these muscles and as well as the cutaneous nerve supply for the median nerve. And if we talk about the lesion of the median nerve, the various deformities which are seen in the lesion of this median nerve, it includes the benediction deformity, then the pointing index, the ape thumb deformity, these will be the lesions which are present or which are associated with the median nerve. The median nerve can be compressed at the level of the carpal tunnel. It is termed as the carpal tunnel syndrome. When we talk about the benediction deformity, when you try to make the fist, the lateral two fingers, they are not able to flex, and this is because the flexor tendons which are coming to these two fingers, they are being paralyzed. So that is why this deformity arises. For the pointing index, when you clasp your hand like this, also known as Ochsner clasp test, then the index fingers, they stand like this because they are not able to flex, and it is known as pointing index. For the ape thumb deformity, because all the muscles of the thenar group, they are affected except the adductor pollicis. So it leads to a condition in which the thumb is adducted and laterally rotated, and this condition is known as ape thumb deformity. Now the test which is used for this median nerve is the pen test, and this is actually testing the opponens pollicis, or we can also say also for the abduction. It is basically checking the abductor or this opponens pollicis. You put the pen over here and you ask the patient to touch the pen. If the patient is able to touch the pen like this, this is that the nerve is intact. So if you come in this, one of the branch of the median nerve is anterior interosseous nerve. The anterior interosseous nerve, it is a branch of median nerve, and it specifically supplies the deep muscles. It specifically supplies the deep muscles of the forearm, that includes the pronator quadratus, flexor pollicis longus, and the lateral half of flexor digitorum profundus. These three deep muscles, these are being supplied by this anterior interosseous nerve. The flexor pollicis longus over here also. So if we come back to the question, it says that which of the following muscles is being supplied by the median nerve. In this, the opponent's pollicis, it is being supplied by it. Adductor pollicis by the ulnar nerve, then lateral half of flexor digitorum profundus. And in this, when we talk about the flexor pollicis brevis, though the flexor pollicis brevis, we know it is supplied by the median nerve, but in that too we say that the superficial head is being supplied by the median nerve and the deep part is supplied by the ulnar nerve. So this flexor pollicis brevis, it is a hybrid muscle or the composite muscle which is having a dual nerve supply. So it is a superficial head which is supplied by the median nerve. So the answer for this question is A, C and D. Next question, the next question is regarding the atlantoaxial joint. So first of all, we will see the atlantoaxial joint. Now this picture, this is showing the atlantoaxial joint. We can very well see over here. This is the atlas and the axis, and it is forming a joint over here. We can see over here, this is the dens or the odontoid process of the C2 vertebra, and it is forming a joint over here. The joint is formed between, this is the anterior arch of the atlas, and towards here, towards the posterior side, we are having a ligament over here which is the transverse ligament. The transverse ligament which is between the lateral masses of the atlas. So this ligament over here is the transverse ligament which is between the lateral masses of the atlas, and it is a part of the cruciate ligament. Now a joint is formed over here, and this structure over here forms a osteoligamentous ring, in between which the dens or the odontoid process, it can rotate. So this kind of joint, it is a pivot joint, and the joint which is formed over here is a median atlantoaxial joint. And this is a pivot. So at this level of the pivot joint, first thing, the rotational movement is possible. And we say that the rotation movement is occurring like this. The rotation movement is like this. So this is termed as side to side movement, and this movement is used when we are saying no. So this joint, it is also known as no type of joint. It is also known as no movement joint due to this kind of action. Another joints which are formed between the atlas and axis, they are at this lateral levels, and they are between the lateral masses of the atlas with the axis, and these are termed as the lateral atlantoaxial joint. So there are total 3 joints between the C1 and C2, the median atlantoaxial and the 2 lateral atlantoaxial joints. Now the rest of the ligaments which are present at this level, now when we see over here, this is a picture in which the half of the vertebrae, they have been removed so as to show the ligaments which are present over here. This is the dens of C2, and over here this bone is C1. This is also C1, this is the anterior arch of C1, and this one is the posterior arch of C1. If you see the ligament which is present over here, from the tip of the odontoid process till the anterior aspect of the foramen magnum, this ligament is the apical ligament. Then just behind that we have one more ligament, this is the cruciate ligament, extending from anterior part of the foramen magnum, and it is going posterior to this odontoid process. This is the cruciate ligament. As we see more posteriorly, there is one more ligament which is known as membrana tectoria. This membrana tectoria again attached anteriorly towards the anterior portion of the foramen magnum, and inferiorly it is going till the posterior surface of the body of C2, and inferiorly it will continue as a posterior longitudinal ligament. This is membrana tectoria. Over it is attached, and inferiorly below it is continuing as the posterior longitudinal ligaments. Then apart from this, anteriorly we are having over here the anterior atlanto-occipital membrane, posteriorly we have over here the posterior atlanto-occipital membrane. Now when we talk about the vertebral artery, we can visualize over here there is an artery which is coming or passing through this posterior atlanto-occipital membrane. This is the vertebral artery. The vertebral artery, it is a branch of the subclavian artery, and to be more specific, it is a branch of first part of subclavian artery. Now after this branch is given, it will ascend in the neck, it ascends in the neck and it has to reach towards the foramen magnum so that it enters the cranial cavity. So therefore it is divided into 4 parts. The first part is the one which is from the origin till it reaches the foramen transversarium of C6. Then the second part is that this artery is traversing through the foramen transversarium of C1 to C6 cervical vertebrae. Then as it comes towards the first cervical vertebra, the third part will begin, in which it will be present, or it will be grooving the upper aspect or upper surface of the C1 vertebra. Then as it enters into the foramen magnum, the artery from both the sides, they come and they unite to form the basilar artery. So this last portion is termed as the fourth part. The various branches which are given off by the vertebral artery, it includes, main branches are anterior and posterior spinal arteries and the pica, which is posterior inferior cerebellar artery. So if we come back to the question, the question says that true about the atlantoaxial joint. When we talk in this, if we see the true about the atlantoaxial joint, the vertebral artery, it passes through groove on arch of atlas vertebra. This is true. It is passing through this. Then apart from this, it is permitting the side to side movement as well as the rotational movements are there. So the answer for this question is A, C and E. The flexion and extension, this movement, it is by the atlanto-occipital joint. The atlanto-occipital joint, which is between the occipital condyles of the base of the skull and the atlas vertebra, and this type of joint, this is the ellipsoid variety of synovial joint, and the movement which are possible over here are flexion and extension, and this is the movement when we are saying yes, this movement is used. So this joint is also known as yes movement joint. The yes movement joint. Now for the next question is regarding the medial meniscus. Now over here, this is a picture of the knee joint which is showing the various structures which are present within the knee joint, and in this we have the intracapsular ligaments and the menisci which is present. Intracapsularly we are having C-shaped menisci which are present over here. The C-shaped menisci or the semilunar shaped menisci, they are having 2 horns, anterior horn and the posterior horn, and both the horns for both the menisci, they are attached to the intercondylar area of the tibia. So in the next picture we can see it is being attached to the intercondylar area. This is the intercondylar area of this tibia, and both the horns, they are attached over here, the medial and the lateral meniscus, and these 2 meniscus, they are intracapsular. Apart from this, we are also able to see the cruciate ligaments over here. These are the cruciate ligaments which are intracapsular. Then extracapsular ligaments which are present on outer side, these are the extracapsular ligaments, the medial collateral and the lateral collateral ligament. So this is cruciate ligament. Over here, this is medial or the tibial collateral ligament. And towards this side, this is lateral collateral ligament. The medial collateral or the tibial collateral ligament, it is a degenerated part of adductor magnus, and the lateral collateral ligament, it is a degenerated part of peroneus longus. Now when we talk about this medial meniscus and the lateral meniscus, the medial meniscus, it is having a characteristic that towards the outer side, it is having attachment with this tibial collateral ligament. Because of its attachment with the tibial collateral ligament, this medial meniscus is more fixed, and whenever movements at the knee joint are occurring, running, walking, so it undergoes the crushing effects of the movement and it is more prone to injury. In contrast to this, when we talk about the lateral meniscus, it is on the outer side, it is actually attached to the tendon of popliteus muscle. and whenever the movements at the knee joint is there, the tendon of the popliteus muscle, it will contract and it will pull the lateral meniscus towards the outer aspect or towards the periphery, due to which it is undergoing less of the crushing effect and it is less prone to injury. So the medial meniscus, this medial meniscus, it is more prone to injury. And the reason behind it is fixed and it is having attachment with tibial collateral ligament, attached to the tibial collateral ligament. When we talk about the menisci, they are having an outer aspect and the inner aspect. Towards the periphery side or towards the outer side, it is supplied by the arteries or the capillaries which are present in the capsule. So the outer area is more vascular, and towards the inner side, the inner aspect is less vascular. So whenever the injury is occurring, it affects the inner area more, which cannot heal very well because it is less vascular. Now if we come back to the question, the question says the true about medial meniscus is that the medial meniscus, it is made up of hyaline cartilage. It is not made up of hyaline cartilage, it is basically made up of fibrocartilage. Then injury of lateral meniscus is more frequent. We have just discussed that it is the medial meniscus which is more, the injury is more frequent. Then it is C-shaped, it is fixed to medial or the tibial collateral ligament, and inner part is more avascular. So the answer for this question is C, D and E. The next question, question number 215, it says that the fibrocartilage is found in. So we will just discuss the locations, the various locations of the cartilages. Now when we talk about the cartilage is divided into three types: the hyaline cartilage, elastic cartilage and the fibrocartilage. The hyaline cartilage, all of them, they are having matrix cells and the fibers. In the hyaline cartilage, predominantly we are having the collagen fibers, but it appears to be homogeneous in appearance because the refractive index of the collagen fibers is same as that of matrix. And a characteristic feature of the hyaline cartilage is that the chondrocytes in the lacunae, they are present in a group of 3 or 4 and it is termed as cell nest. When we talk about the elastic cartilage, there are more of elastic fibers and the cells or the chondrocytes, they are present singly. And if we talk about fibrocartilage, the fibrocartilage is the one which is not covered by the perichondrium. A lot of collagen bundles are there and less number of cells are there, and the cells, they are typically present in the form of rows. Regarding the location where these cartilages are present, the hyaline cartilage, it is typically present in the respiratory system. It is present in the tracheal cartilage, it is present in the bronchus also, so bronchial cartilage, and as well as in the nose, the nasal cartilage. So the cartilages which are present in the respiratory system, they are of hyaline type. Then apart from this, the costal cartilage, articular cartilage, the articular cartilage which is present in the synovial joints, then epiphyseal plate. All these are hyaline. Then in the larynx, the various cartilages which are present in the larynx, we have the thyroid cartilage, cricoid and the base of arytenoid. These are hyaline in nature. So all these cartilages, they are hyaline in nature. Now if you talk about the elastic cartilage, it includes epiglottis, ear pinna, external auditory canal, then eustachian tube. So 4 E are there, E in of each word. So all these are elastic cartilages. Apart from this, we have apex of arytenoid, corniculate and cuneiform cartilages. So these are elastic cartilages. For the locations of the fibrocartilage, it is characteristically present in the intervertebral disc, then the disc within the pubic symphysis, so interpubic disc. Apart from this, in the menisci of knee, the menisci of the knee joint, then the articular disc. The articular disc, which is present in some of the synovial joints, and that includes the sternoclavicular joint, temporomandibular joint, as well as the articular disc, it is present in the inferior radioulnar joint. Then fibrocartilage, it is also present in acetabular and the glenoidal labrum. Which are present in the hip joint and the shoulder joint. So these are the locations of the cartilages in the body. So we come back to the question. The question says that the fibrocartilage, it is found in, so as we have just discussed, it is found in the articular disc, which is present in sternoclavicular and the temporomandibular joint, as well as over here, if we talk over here, the intervertebral disc, and towards inferior radioulnar joint. The inferior radioulnar joint, one side it is completed by the articular disc, which is present, and that is the fibrocartilage. So the answer for this question is A, B, D and E. The next question, it is regarding the supply of the pectoralis major muscle. When we talk about the pectoralis major muscle, the pectoralis major muscle, it is actually present in the pectoral region, and the origin is wide and its insertion is narrow. When we talk about the origin is from the medial 2/3 portion of the clavicle, its anterior surface. Then towards the median side, we have the origin from the anterior aspect of the sternum. So it is from the lateral portions of anterior surface of the sternum till the attachment of the 6th rib, as well as it is taking origin from the 2nd to 6th costal cartilages and the aponeurosis of external oblique muscle. When we talk about the insertion, so for the origin we have just mentioned arising from clavicle, then from sternum, 2nd to 6th costal cartilage and external oblique aponeurosis. For the insertion, the fibers, they go towards the lateral aspect and they are attached to the intertubercular sulcus. In the intertubercular sulcus, they are specifically attached to the lateral lip of intertubercular sulcus. The intertubercular sulcus, it is also known as the bicipital groove. When we talk about the nerve supply of this muscle, it is being supplied by medial and the lateral pectoral nerve. The medial pectoral nerve, branch of the medial cord of brachial plexus. The lateral pectoral nerve, it is a branch of the lateral cord of brachial plexus. The action of this muscle, it is mainly helping in the adduction of the shoulder and the medial rotation. Now, when we talk about the blood supply of this muscle, it is mainly supplied by the pectoral branch of the thoracoacromial artery. So the main supply is by this pectoral branch of thoracoacromial artery. Apart from this, it is also supplied by perforating branches of internal mammary artery or the internal thoracic artery, and the supply is also by branches of intercostal artery. Now, if you come back to the question is regarding the blood supply of the pectoralis major muscle, and over here the answer will include A, B and E. Now the next question is regarding the otic ganglion. Now when we talk about the otic ganglion, let's first discuss regarding the otic ganglion. Now this picture is showing the Otic Ganglion. This is the Otic Ganglion which is present over here. This is the location of Otic Ganglion, and it is present just below the foramen ovale. This is the location of foramen ovale through which the mandibular nerve will be passing, and just below the foramen ovale we have the presence of the Otic Ganglion. This Otic Ganglion, this is one of the parasympathetic ganglion of head and neck, and it is topographically related to this mandibular nerve. So topographically it is related to the mandibular nerve, and functionally it will be related to the glossopharyngeal nerve, and in this specifically the lesser petrosal nerve. So topographically related to the mandibular nerve, and functionally it is related to the glossopharyngeal nerve, specifically the lesser petrosal nerve, and is lying just below the foramen ovale. Now if we talk about the relations of this Otic Ganglion, then just anterior to it we have a muscle, medial pterygoid muscle, and posterior to it the Otic Ganglion is present middle meningeal artery. The middle meningeal artery. Then medial to it, medial to the Otic Ganglion, the tensor villi palatini muscle is present, and lateral to it we have the mandibular nerve. So these are the structures which are related to this Otic Ganglion. Now regarding the various roots which are present in the Otic Ganglion, we are having the parasympathetic root, sympathetic root, sensory root, and apart from this it is also having the motor root. If we talk about the parasympathetic root, which is carrying the secretomotor fibers, this root, the fibers for this root, they will be arising from inferior salivatory nucleus. The fibers, they arise from inferior salivatory nucleus, they reach towards the glossopharyngeal nerve, and in the via the glossopharyngeal nerve a tympanic branch is given, the tympanic branch of the glossopharyngeal nerve, which forms the tympanic plexus. Now a branch of tympanic plexus termed as lesser petrosal nerve, it goes and relays in the Otic Ganglion. It will relay in the Otic Ganglion. Now these fibers which are present over here, these are termed as the Preganglionic Fibers. Now when this nerve, it will go and relay into the Otic Ganglion. Now the fibers which will arise, they will be known as the postganglionic fibers, and they will be passing through the auriculotemporal nerve, and it will reach towards the parotid gland. So these are the postganglionic fibers. So therefore this ganglion, it is basically for the supply of the parotid gland, for the secretomotor supply. If we talk about the sympathetic root, the sympathetic root or the fibers in the sympathetic root, they pass through the Otic Ganglion without any relay, and same is for the sensory and the motor fibers, motor roots also. Only the parasympathetic fibers are the one which relay in the Otic Ganglion. The parasympathetic root, the fibers, they are basically arising from the superior cervical ganglia, and then they form a sympathetic plexus around the middle meningeal artery. They form sympathetic plexus around middle meningeal artery, and the branches, the branch, it arises from this plexus and it reaches and it forms a sympathetic root. It relays, it does not relay in the Otic Ganglion, it passes as such, and it will be passing towards the parotid gland. So it is basically supplying, giving a vasomotor supply. Now if we talk about the sensory root, the sensory root, it is the fibers are passing through the auriculotemporal nerve, And over here also the fibers, they are passing without any relay through the otic ganglion. For the motor root, when we talk about the motor root, the fibers for this, they are passing specifically through the nerve to medial pterygoid. The nerve to medial pterygoid, it is one of the branches of the mandibular nerve. The motor fibers, they pass through it. They then then they pass through the otic ganglion without any relay. The otic ganglion, and the fibers are then distributed to two muscles, which are the tensor tympani and the tensor villi palatini muscle. Now over here, if you see this picture, it is showing the same thing, the distribution through the otic ganglion. These are the fibers over here, which are actually the sympathetic fibers coming from the superior cervical ganglion, forming a plexus around the middle meningeal artery, and then it passes through it without any relay. These are the parasympathetic fibers arising from this nucleus, forming tympanic plexus. Then the fibers, they come over here, they relay, and after that it will be passing through the auriculotemporal nerve. Now if we come back to the question, now in this we have to find what is the true statement about the otic ganglion. Now regarding the otic ganglion, the lesser petrosal nerve, it forms the parasympathetic root, this is correct. Then it is carrying the secretomotor fibers. Topographically it will be connected to mandibular nerve. The nerve to medial pterygoid is also connected to ganglion because it is carrying the motor fibers. And the sympathetic root, it is actually derived from plexus around the middle meningeal artery. So answer for this question is A, B and D. Question number 218, it is regarding the common peroneal nerve injury. Now this is the picture which is showing that what happens in the common peroneal nerve injury. If the nerve it is affected over here, it will lead to foot drop, and in the foot drop there will be inability to lift the front part of the foot off the ground. That means there will be loss of dorsiflexion as well as there will be loss of inversion. Now if we talk about the common peroneal nerve, the common peroneal nerve, it is one of the terminal branch of sciatic nerve. The root value of this is from L4 to S1, and this branch it is given off in the popliteal fossa. Then it winds around the neck of the fibula and it reaches towards the anterior side. So one of its characteristic feature is it winds around the neck of fibula. Now after it winds around the neck of the fibula, it will reach towards the anterior compartment or anterior side of the leg, and as it reaches the anterior side of the leg, this common peroneal nerve, it divides into two branches. It divides into two branches, and those two branches are superficial peroneal nerve and the deep peroneal nerve. Now this deep peroneal nerve, this is the nerve which will be supplying all the muscles of the anterior compartment. It supplies all the muscles of anterior compartment of leg. And this superficial peroneal nerve, this will supply all the muscles, of the lateral compartment of leg. So the deep peroneal nerve supplies all the muscles of anterior compartment. That means it will be supplying the tibialis anterior, extensor hallucis, extensor digitorum and peroneus tertius. And these muscles, because all these muscles, they are responsible for dorsiflexion of the foot. So if there is any injury of common peroneal nerve or of the deep peroneal nerve, it will lead to loss of dorsiflexion. The superficial peroneal nerve, it supplies all the muscles of lateral compartment of leg, and that includes the peroneus longus and the peroneus brevis. Both these muscles, they help in the eversion of the foot. So if the common peroneal nerve is injured, so these muscles will also be affected or paralyzed, so there will be loss of eversion. So when we talk about the foot drop, it is due to the common peroneal nerve injury. The common peroneal nerve injury is there, and the injury will be at the level of, most commonly it is at the level of neck of the fibula. Either there will be injury at this level, or the compression over this level, like compression by a tight plaster may be there. So whenever this happens, there will be lesion of common peroneal nerve, and it will lead to a condition where there will be loss of dorsiflexion and eversion. The loss of dorsiflexion and eversion, the loss of eversion is there due to the involvement of these specific muscles. And the foot, foot is in equinovarus position. The foot is in equinovarus position, that means the foot is plantar flexed and it is slightly inverted because of the unopposed actions of these other muscles. In such kind of lesion, all the reflexes are intact. The reflexes are affected if the sciatic nerve will be affected. Now there will be a sensory loss. The sensory loss is also there because these nerves, superficial and deep peroneal nerve and the common peroneal nerve, they are supplying specific regions of the leg as well as the foot. Now over here, if we see, this picture is showing the cutaneous supply of the lower limb region, and in this, if we see towards the leg side, towards the anterior lateral aspect, this is the anterior lateral aspect, this is supplied, the skin over here is supplied by the common peroneal nerve, as well as we come lower down, the superficial peroneal nerve, it is supplying this anterior aspect, as well as it is going towards this dorsum of the foot. Then the first, this is the superficial peroneal nerve, then the common fibular nerve. The deep peroneal nerve, it supplies the first web space, so whole of this dorsum of foot, it is being supplied by this. So if common peroneal nerve injury is there, there will be sensory loss in the anterior lateral aspect of the leg as well as towards the dorsum of the foot. Only the portions which will be spared will be towards the medial border and towards the lateral border of the foot, because towards the medial border, it is supplied by saphenous nerve. It is supplied by saphenous nerve, and towards the lateral border, it is supplied by the sural nerve. And the medial aspect of the leg, it is also supplied by the saphenous nerve. The saphenous nerve is a branch of the femoral nerve. So sensory loss will be observed in this area. Now apart from these characteristics which are present, the gait of the person is also affected, and there will be high steppage gait. The high stepping gait will be there because the foot drop is there. So when such kind of person he tries to walk, the foot or the toes, they lag behind, and the person has to lift his foot or lift his leg so that he can move forwards. So that is why we use the term as high stepping gait. Now if we come back to the question, the question says that which of the following may occur in the common peroneal nerve injury. So dorsiflexion is lost, foot drop will be there, the high stepping gait is there, then loss of eversion is there. So eversion of foot is affected. So the answer for this question is A, B, C and E. The next question is O'Donoghue triad, it comprises of. Now this triad is also known as unhappy triad. This is also known as unhappy triad or the terrible triad, and this is because there is involvement of important ligament or the menisci of the knee joint, and it involves there is a tear of anterior cruciate ligament, along with that the medial meniscus and the medial collateral ligament. These three specific structures of the knee joint, they are involved in this, and this is termed as O'Donoghue triad. So the answer for this question is A, C and E. Now the next question is valvulae convenientis, they are seen in. Now it is also known as wall of Kerckring, the wall of Kerckring, or also known as plica circularis. Now the specific characteristic of this wall of Kerckring or plica circularis is that these are the mucosal folds and they are permanent in nature. So if there is distension of the intestine, they will still be there. Now if you see this picture over here, this picture is showing that how the plica circularis are present. Now this picture, in this we have done the cut section of the intestine, and this is the duodenum over here. And if you see the cut section of the duodenum, on the internal aspect we can see the folds. These folds, these mucosal folds, these are known as plica circularis, and this section has been taken in the portion of distal ileum. In the distal ileum we can see very slight folds are there, very less folds are there, and they are very small folds or very less folds are there. Now these plica circularis, these are basically the folds, mucosal folds, which will increase the surface area of absorption. So they are to increase the surface area of absorption, as well as they will slow down the movement of the whatever material is there, and so that the absorption will be more. Apart from this, the presence of these plica circularis, this is present just after the second part of the duodenum, and they are more in number after the major duodenal papillae of the duodenum, and they are maximally seen in the duodenum portion and in the proximal ileum. As we move towards the distal portion of the ileum, in the distal ileum they decrease in number, they are scarce and very less, or they are quite broadly spaced. So this is a feature of the small intestine. And to be more specific, it is characteristically seen in the duodenum, and apart from this, seen in the duodenum, distal to second part, or from second part, and in the proximal ileum. So now if you come back to the question says that the valvula convenientis, it is seen in. So it is seen in the duodenum as well as it is seen in the proximal ileum. So the answer for this question is A and B. The next question, 221 question, it says the cranial nerve passing through internal auditory meatus. Now the cranial nerve which passes through internal auditory meatus, it includes the facial nerve, the vestibulocochlear nerve. Apart from this, the sensory root of facial nerve, that is nervus intermedius. And along with this, we are having labyrinthine vessels. These are the structures which are passing through the internal auditory meatus. So the answer for this question, over here only one option is mentioned, so answer is A. Now if you see the various other foramens which are present in the cranial fossa, this is a picture of the cranial fossa showing the cranial cavity, in interior aspect of the cranial cavity, showing the anterior cranial fossa, middle cranial fossa and the posterior cranial fossa. If we focus over the anterior cranial fossa, we can see at this side, this is the cribriform plate of the ethmoid, and through this passes the olfactory nerve, the rootlets of the olfactory nerve. So the olfactory rootlets or this cranial nerve is passing through this. Then at the junction of anterior and the middle cranial fossa, a rounded foramen which is present over here is the optic canal, through which the optic nerve is passing along with the ophthalmic artery. Then a slit-like space is present over here at the junction of anterior and the middle cranial fossa. This is the superior orbital fissure, and which is mainly giving passage to 3rd, 4th and 6th cranial nerves. Apart from this, it is giving passage to the ophthalmic nerve The ophthalmic nerve, which is one of the divisions of the trigeminal nerve, and this ophthalmic nerve, as it reaches this supraorbital fissure, it divides into frontal nerve, lacrimal nerve, and the nasociliary. So all these nerves will be passing through this supraorbital fissure. Apart from this, it also gives passage to superior and inferior ophthalmic vein and the recurrent meningeal branch of the lacrimal artery. Then in the middle cranial fossa, we are having three foramens which are present one after the another. Just anteriorly over here, this is the foramen rotundum, then an oval foramen ovale, and just behind a small round foramen is present, which is the foramen spinosum. The foramen rotundum, it gives passage to the maxillary nerve. The foramen ovale, it gives passage to male, that includes the mandibular nerve. The sensory root of the mandibular nerve, it is passing through this, and apart from this, the motor root of trigeminal is also passing along with it. The motor root of fifth cranial nerve. Then from A we have accessory meningeal artery. L is the lesser petrosal nerve, and E is the emissary vein. All these structures, they are passing through the foramen ovale. Through the foramen spinosum, the structure which is passing is middle meningeal artery. Now at the junction of the middle cranial fossa and the posterior cranial fossa, just over here we have the foramen lacerum, which is not giving passage to any significant structure. Only the ascending pharyngeal artery is the one which is passing through it, or the emissary vein is the one which is passing through it. Then towards the posterior cranial fossa. This is a location where the internal acoustic meatus is there. Then just behind it we are having an irregular foramen known as jugular foramen. This is the foramen magnum, and just on lateral aspects of the foramen magnum we have the hypoglossal canal. And these are the foramens which are giving passage to rest of the structures. As we have just discussed, through internal acoustic meatus 7 and 8 and nervus intermedius, along with that labyrinthine vessels are passing through it. Then through the jugular foramen, 9th, 10th and 11th cranial nerve are there. Internal jugular vein, it is passing through it, and inferior petrosal sinus. Through the hypoglossal canal, the 12th cranial nerve is passing through it, and through the foramen magnum, the lower portion of the medulla oblongata, it continues as a spinal cord. Along with that, the three meninges are passing. The two vertebral arteries, they are passing through it. Then the accessory nerve, the spinal part of the accessory nerve, it is also passing through it. Anterior and the posterior spinal arteries also. Through the anteriormost part of the foramen magnum, it is giving passage to the apical ligament, membrana tectoria, and the cruciate ligament. So all these are the structures passing through the various foramens which are present in the cranial cavity. The next question, it is regarding the latissimus dorsi. Regarding the latissimus dorsi, this is the muscle of the back, and it is a major muscle which is present towards the lower back. So if we talk about the latissimus dorsi, this muscle, it is the origin of this muscle. If we talk about the origin of this muscle, it is arising from the iliac crest, and in the iliac crest it is arising from the outer lip, the posterior 1/3. The posterior 1/3 part of the outer lip. Then apart from this, it is arising from the thoracolumbar fascia, and to be more specific, from the posterior layer of thoracolumbar fascia. Then few fibers, they arise from the inferior angle of the scapula, and they are fibers which are actually all also arising from the spinous process of T7 to L5, and mainly it is from T7 to T12, the spinous process of this. They are basically giving rise to the latissimus dorsi. Now this is a large muscle, it is having a large origin over here. We can see it is arising from this whole aspect, and as it goes towards the insertion point, it is having a narrow insertion, and the insertion is in the bicipital groove. The insertion, it is in the floor of the bicipital groove or the intertubercular sulcus. The bicipital groove also known as intertubercular sulcus. The nerve supply of this muscle, it is being supplied by the thoracodorsal nerve, the root value for this is C6, C7 and C8. This thoracodorsal nerve, it is one of the branches of the posterior cord of the brachial plexus. Then the action of this muscle, the major action of this muscle is it is helping in adduction, extension and medial rotation. Now this is the action which is mainly helpful when you are climbing a rope or during the swimming, and due to this muscle is also known as climber's muscle. It is also known as the climber's muscle. When we talk about the blood supply of this muscle, this blood supply is mainly through the thoracodorsal artery. This thoracodorsal artery, it is a branch of subscapular artery, and this subscapular artery is in turn a branch of the third part of the axillary artery. So mainly the blood supply of this muscle is by the thoracodorsal artery, mainly by this, and also it is also supplied by the intercostal artery as well as the paraspinal arteries also. Now this muscle is a muscle which is which can be used to fill the defects of the back apart from the trapezius. Towards the 1/3 of the back, mainly the trapezius is used to fill the defects. Along with that, latissimus dorsi can also be used. In the middle 1/3 portion, the latissimus dorsi is the one which is used, and towards the lower 1/3 we use the gluteus maximus. So in this, if we come back to the question, the question says that true about the latissimus dorsi is that it is inserted in the bicipital groove, in the floor of the bicipital groove of humerus, as well as it is used to fill up the back defects. The blood supply, as we have just discussed, it is from the thoracodorsal artery. So the answer for this question is B and C. The nerve supply, as we have just discussed, the nerve supply is by the thoracodorsal nerve, and origin we have already discussed. So thanks to all of you. This completes the anatomy portion.